Dear friends, welcome back. Today we're fortunate to have Dr. Russ Adams with us, and we're going to talk about palliative care and hospice care. Dr. Adams is the Chief Medical Officer at Allen Hospital and also the Director of the Hospice Program and oversees the Palliative Care Program. I would request him to introduce himself on those credentials a little bit more. Many of you would have known him. He's a very well-respected physician at Allen and in our community. And we're very fortunate that we have some time with him to understand the differences between palliative care, hospice care, how we can use this information to help care for our loved ones in a better way. So that's the goal of our discussion today. Welcome, Dr. Adams. If you want to introduce a little bit more about what led you to this and what your credentials are on this one.
Well, good morning. As Dr. Ravi has indicated, I'm an internal medicine physician and was in clinical practice for quite a number of years. I became interested in palliative care and hospice care mainly because we have patients that have a chronic medical illness, and how do we negotiate through those illnesses when they're either continuing with treatment or they've decided not to continue with any additional treatment and just want to be comfortable. That provided me with an insight into the other needs as far as what our patients require. And so I became interested initially in palliative care and then in hospice care, and have been involved with both entities for quite a number of years now. One of the questions that many ask is, what is the difference between palliative care and hospice care? There is a difference and there are similarities. When we look at palliative care is for a person who has a serious chronic medical illness that they still are wanting treatment for, but they are uncomfortable. They're having symptoms of pain or shortness of breath, they're having symptoms of nausea or abdominal pain, or some symptoms that are making them feel less well. Palliative care is an ideal option for that type of person, in that they will help as far as working with the practitioner who is providing their care and trying to make sure that they're comfortable, trying to help also family members who are providing additional support for them, providing education as far as what is going to happen in the future, also information when they have questions about the care that they're receiving as far as why they're receiving that care. And this is something that when a person has palliative care, it is something that a person is already continuing to seek additional care from their practitioner. They're wanting to have as much treatment as they can to try to get better, recognizing that they will not be cured of that illness. An example of that would be a person who has chronic obstructive pulmonary disease, which is a respiratory problem where they want as much treatment as they can get, but they know that this problem is not going to be cured. And so that's a prime example. As compared with hospice, hospice is where we have a person who has a serious medical illness and is perceived that the life expectancy is 6 months or less. This has to be determined by their primary care provider and the hospice director. When that has been determined and the family and patient have had discussion regarding this and have decided that they do not want any more treatment specific to that problem, but want to be as comfortable as possible. They want their symptoms taken care of as far as pain and suffering, and they want to be as comfortable and enjoy life as much as they can in the time that they may have left. That is the main difference between palliative care and hospice care. Now, with hospice care, a person's care is covered by Medicare, Medicaid, and other insurances. With palliative care, there are some insurances that will cover that. There are other insurances that will not, and then it is an out-of-pocket responsibility. Both entities, though, provide not only the care for symptoms, but they also provide that emotional support, that spiritual support that one needs, not only for the patient, but also for the family. When we look at hospice care, that spiritual and emotional support, in fact, goes for another 13 months after the patient has met their demise.
So, I think, Russ, on the so the specific issues then that hospice and palliative care can address in a little bit more depth in conjunction with their outpatient practitioners, right? It'd be a little more depth on the emotional issues, these are issues, and a little more depth on the physical symptoms such as pain or discomfort or difficulty breathing. So there's a medical aspect to it, and then there's a emotional aspect to help attitudes and acceptance of issues of both chronic illness as well as death and dying.
Yeah, exactly. And in fact, what we sometimes forget as practitioners is, say a person has a lung problem, they may have other medical issues that are also problems. And so in palliative care and in hospice, they will help address those issues to try to improve the comfort of the individual with those other medical problems also. It's easy for us to maybe have an example, say a person that has pancreatic cancer. And it's been told by the practitioner that this is not something that we can cure. But the patient decides, I want as much treatment as I can get. Ideally, right at that time, palliative care would be ideal. And they would be involved in helping to provide that comfort, the education, looking at the other medical problems that person might have to help them with that. And then when it gets to a point where the patient and family have decided, well, enough is enough, we just want to be as comfortable as possible, then that would be a transition to hospice care.
So in the hospital setting, is this at Allen Hospital, is this by patient request, or is this by a protocol? How should patients ask for it or advocate for themselves, or are we able to do it, and how can they do that on the outpatient setting?
Okay.
How should they approach it?
So both are available on the outpatient setting. And so if a patient wants to have palliative care or they decide on hospice care, that is really a communication that they have with their practitioner, and that practitioner can arrange the appropriate setting for them. If you look at palliative care, most of the palliative care is performed in the out-of-hospital setting, but also in the hospital setting when a person comes in, they're told that they have this illness that is very serious, is going to be lifelong, then it's very appropriate for the patient to say, well, I'd like to entertain evaluation by palliative care, or the practitioner might approach them and say, should we have palliative care involved at this point in time? And that's not giving up on treatment, it's just simply trying to augment the treatment to make sure that we're taking care of our patient, but also the family as well as we can. With hospice care can be referred in the out-of-hospital setting, it can be referred on the in-hospital setting. What we have found with hospice care is really, what we found is that people who sign up for hospice care earlier on in their illness tend to live longer, and they have a better quality of life because the treatment then is everything for comfort, nothing that goes against providing comfort for the individual. And so that's where the goal is to get hospice care provided when the patient has decided and family has decided that this is what we need to consider. Now, a good option for families and patient is to say, well, I don't know much about hospice. Could I have someone come out and talk to me about it? And that is something that is done where they'll come out to your home, they'll talk to you about hospice and what can be offered, and then a family and patient can decide, is this what I want to do? Same goes for palliative care.
So on the outpatient setting then, if there's palliative care or hospice, how does that work? Is there a nurse that goes out? Is there what's the mechanics of the support that can happen as an outpatient? The
mechanics are initially the nurse goes out and discusses with the patient and family what the services are, and then if the family decides on, yes, we want to go forward with this, then we have nurses that will go out and also help with the care of the patient. We have social workers that will go out also, and also our spiritual care. If the family is in agreement, we'll have our pastors go out and also provide that spiritual, emotional support.
So the team is then talking to the palliative care or hospice medical director, but they're also at the same time coordinating care with their own primary care providers. So
Absolutely.
it does not replace that.
Absolutely, absolutely. When you talk about palliative care, it's working in concert with their care provider. When you talk about hospice care, usually the communication is also with their care provider, but usually a lot of the treatment then is monitored and managed by the hospice director, but the practitioner who provides their care over the years is also aware of everything that's happening and has input.
So in other words, the team becomes a little bigger.
It's bigger.
We don't lose the primary care or their primary provider, but it just becomes a little bigger, and there's more resources
Exactly.
To deal with that. In terms of palliative care, so the best way then for our patients to approach is to go through their primary care provider if this topic interests them. And also, I think part of this, friends, is to educate all the providers as well, because we as providers, we don't understand that as much. So it's a combination of education of the patients and all the providers too, so that we are all working together on your behalf to take care of chronic illness or to take care of end-of-life issues.
Yeah, exactly. In fact, for the palliative care, what happens is that if the patient has decided that they want to proceed with that, the palliative care team will work with the practitioner, whether it's the primary care provider or the specialist, or both, as far as what they want that patient to receive, and they will help in making sure that the patient understands that, make sure that the patient is not having any side effects associated with that, and that that the patient is actually doing what they're supposed to do to try to improve their quality of life with that. So it's really a team approach. You're just adding an additional part of that team that is looking at it from a little bit different focus, looking not only at the specific problem that that person is having, but the entire patient, but also including the family in that, because oftentimes it's a matter of explaining to the family what is going on, what are your doctors trying to do, and helping to provide that glue for the care of the patient.
Thank you, Dr. Adams, for joining us. We will have on the on this end of this topic some contact information as to if you want to reach out for more information about palliative care or hospice or have more questions. Please look at this reference that we have on this slide for you to go and check those resources out. Thank you again. Please pass the word around. This is a wonderful resource that's in our community for care of our loved ones. If you have more questions, please always feel free to email or call. Thank you.